Today we'll be discussing the Not on Tobacco program. We'll start with what the program is and who it's targeting. The NOT program was developed by the American Lung Association as a gender-sensitive, school-based program geared to provide an easy and effective way to help adolescents quit smoking. The program is designed specifically for 14 to 19-year-olds who are regular smokers and likely addicted to nicotine. In order to participate in the program, the adolescent must volunteer and want to quit smoking. The curriculum of the program includes 10 50-minute sessions where gender-specific issues are highlighted. In addition, the program uses teen-friendly language and focuses on issues relevant to teens. Teens are encouraged to learn in a wide range of activities such as small group discussions, role plays, and journals. Also, 4 optional booster sessions are offered after the program's completion. Overall, this program strives to provide a total health approach to teen smoking cessation. The program goals are to help teens quit smoking, reduce the number of cigarettes used by those who are having difficulty quitting, increase healthy lifestyle behaviors, and improve life skills such as stress management, decision-making, coping, and interpersonal skills. The key question researchers hope to answer in developing and implementing this program was, will or does the NOT program reduce teen smoking? In addition, they may have also wanted to address whether different ethnic groups respond the same. As we move on through the slides, we'll see that not only was the program successful, but it appeared to be equally as effective amongst different groups. So now that we know what the program is, who it's geared towards, and what it hopes to accomplish, let's get into the multiple determinants of health factors that contribute not only to teens initiating and continuing to smoke, but how these factors may impact the effectiveness of the program. Some of the most important factors are listed here: low income, social marginalization, behavioral factors, poor education, and gender issues. Low income and poor education are the 2 most influential determinants of health. Researchers have found that reducing smoking prevalence is much lower among populations of low socioeconomic status, which is characterized by low income, low levels of education, unemployment, and blue-collar and service industry workers. This means there is a large disparity in cigarette smoking between low and high socioeconomic status smokers. However, to achieve a national decline in smoking prevalence, this and other disparities must be eliminated. Low socioeconomic status also contributes to other factors like social marginalization, which are associated with smoking behavior. Tobacco use is increasingly dominated by marginalized groups such as Indigenous people, homeless people, and those with substance abuse and mental illness. Smoking exacerbates poor health, social, and financial inequities experienced by these vulnerable groups as well. To combat these inequities, researchers developed this program in such a way that it could reach all populations. Teens can access and participate in this program through school. In addition, the developers hoped that this program could provide educational alternatives to punitive measures such as suspension for kids caught smoking during school. The program is to be used as a voluntary approach, allowing schools to assist and support students who want to stop smoking. This sets a more positive and more encouraging tone than responding to teens that break the rules. Because this program's focus is on teens, the content is tailored to be easily understood and teen-friendly. The program is also tailored to each gender with tips for girls and tips for boys in each session, as well as handouts that are gender-specific. The program is designed to be delivered separately with same-gender facilitators, allowing educators to focus on the specific needs and concerns of each gender, while also allowing teens to feel more comfortable and open to share in their groups. Another factor impacting the effectiveness of the program is addressing the priorities of the community. Here, teen smoking cessation, as well as reducing smoking initiation, are major priorities. Multiple studies have found that adults who smoke often started in high school before the age of 18. The program looks to address these issues by ensuring that teens are prepared to quit and not relapse by including conversations around motivation, stress management, the effects of smoking, preparing to quit, relapse prevention, healthy lifestyle, and a handful of others. As teens successfully quit, it too helps to change social norms around smoking. Kids see their friends quit smoking, which makes them want to try to quit, and other friends that haven't begun smoking may not want to start. This ultimately aids in the reduction of smoking initiation in this group. So how was this program brought to fruition? There were many key players in the dissemination and implementation of the NOT program throughout the U.S. The state of West Virginia has one of the highest smoking rates in the U.S., and because of this, was particularly interested in teen smoking research, cessation, and prevention. In 1995, before the program was developed, West Virginia University Centers for Public Health Research and Training, or the PRC, was conducting research on teens who smoke. The PRC then formed a partnership with the West Virginia State Health and Education Departments, the Coalition for a Tobacco-Free West Virginia, and the ALA, which helped develop this program. The initial version of the NOT program was developed with all of these groups and is now considered the model group by the ALA. Other key players that are important to consider are the counties and schools offering the program, as well as the facilitators of the program. Schools that want to offer this program have a program facilitator trained and certified by the ALA. Facilitators are provided with a facilitator guide that includes the details on the content of the curriculum and extensive guidance on program delivery. It also includes guidance and materials for conducting in-service training sessions for school personnel, integrating NOT with school goals, recruiting participants, making mental health referrals, addressing gender issues, evaluating the program, and delivering booster sessions. In addition to these key players, there was also some external stakeholders that were interested and involved, such as the federal and other government agencies. Groups like the CDC, the FDA, state public health departments, and the National Registry of Effective Programs, or the NREP, and the Substance Abuse and Mental Health Services Administration. Groups like these are important in recognizing and validating the effectiveness of the program and increasing support of dissemination. The NOT program was recognized as an effective program by the NREP and is included as a model program on the Substance Abuse and Mental Health Services Administration's website. Positive endorsements from groups like these are important in community and public understanding and trust, which in turn aids in the adoption of the program nationwide. So being that this is a school program for teens, the largest piece of the community involved is the school system itself, including teachers or other staff interested in becoming program facilitators, as well as parents and the students. Once facilitators are fully trained and certified, they conduct group sessions, creating a community sense amongst the teens participating. Tobacco cessation and prevention programs are typically funded by states themselves through taxes and tobacco settlement payments, with funding varying from state to state. In addition, states receive federal funding from the CDC and the FDA. The CDC recommends states to maintain specific funding levels for tobacco control programs. However, only 2 states, Alaska and North Dakota, are currently funding their programs at the recommended levels. In order to raise additional funds for tobacco cessation programs, I would work with other private groups to raise money, such as doctors, hospitals, and other parties interested in the cause. So how do we go about getting community buy-in for a program like this? Being that this is school-based, I would want to start with the parents, schools, and teachers. We want to get them on board so that we can then begin marketing to the kids. To get their buy-in, I would first provide research data regarding teen smoking to make them aware of the problem through the use of commercials, pamphlets, and/or hosting meetings at the schools. I would want to highlight, for example, the following data and the fact that reducing smoking initiation in this age group is imperative and could be an effective method to reducing long-term smoking rates. So, for example, around 87% nationally of all adult cigarette smokers began smoking by the age of 18. In California, about 67% of current and former smokers started by the age of 18 and 98% by the age of 26. In addition, if parents are unaware, I would also want to call out specific risks associated with smoking, such as cigarette smoking is the leading preventable cause of death in the U.S., and that smoking causes about 90% of all lung cancer deaths in men and women. Once this group agrees there is a problem and the community needs help addressing it, I would share the plan of our NOT program, who will be targeting, how it works, the proven effectiveness, and how they can support their students in completing the program and ultimately quitting. Next, we want buy-in from the teens themselves. As mentioned previously, the program is school-based and voluntary, so we want teens to want to quit and to want to participate in the program. In this day and age, teens are constantly on their cell phones and other forms of technology, so we would want to tailor our marketing strategy to connect with them in this way. The most effective way to accomplish this would be by providing information through various social media outlets, which can then be shared from peer to peer. I would want to share similar information that I included for the parents and teachers in terms of risk associated with smoking, but also aim to keep the content teen-friendly using images, infographics like this one on this page, and short videos with youth-friendly music, animations that are quick to look at and easily shared. Overall, the NOT program has been fairly well received, and the ALA has adopted it as a national best practice model. It has also been included as an effective program in the NREP, as well as on the Substance Abuse and Mental Health Services Administration's Model Programs website. From 1999 through 2010, more than 150,000 teens in 48 states had participated in the program. With its positive reputation, I have found little to no ethical concerns regarding the development or implementation of the program. So though health experts agree, and most communities agree, on the importance of teen smoking cessation and prevention programs like NOT, this program still faces opposition, mostly with the tobacco industry. In the early 2000s, thousands of internal tobacco industry documents were released through litigation and whistleblowers to reveal various tobacco marketing strategies illuminating their targeting of children. The tobacco companies have consistently denied that they target youth, instead insisting that peer pressure is the most important aspect to adolescent smoking. However, the industry documents revealed that the market of young smokers is of central importance to the industry, with many companies clearly and aggressively advertising to youth and even attempting to manipulate peer pressure to make people smoke their brand. Independent surveys show that roughly 60% of smokers start by the age of 13 and 90% before the age of 20. The tobacco industry, knowing this, purposefully yet illegally advertised to underage teens and children specifically. A sales rep for a tobacco company called R.G. Reynolds recalled, "We were targeting kids, and I said at the time is unethical and maybe illegal, but I was told it was just company policy." In addition to this, these industry documents proved that tobacco companies were well aware of the health risks associated with smoking, all the while denying any correlation between smoking and lung cancer or that their products were actually addictive. So now that we know how the program was developed and implemented, let's look at why. What was the need for this program? Through the past several decades, smoking prevalence among youth has fluctuated greatly, with drop-offs through the late 70s and 80s and large spikes in the mid to late 90s and early 2000s. At the time of the implementation of the NOT program, most of the 45 million adult smokers in the U.S. began smoking during adolescence, and without intervention, most teenage smokers could be expected to continue smoking into adulthood. In 1995, around 23% of teens reported smoking cigarettes, with around 67% of them saying they would like to quit. However, at the time, there were not many programs to help teenagers quit smoking. With spikes in tobacco use, we see spikes in healthcare spending too. New studies have recently claimed that nearly 9% of all healthcare spending, or around $170 billion a year, is for illnesses caused by tobacco smoke, and public programs such as Medicare and Medicaid are paying for most of these costs. Because smoking can cause disease and many of the body's organs, and smoking-related healthcare costs affects most type of medical care, a huge burden is placed on the nation's healthcare institutions, especially those funded by the public's tax dollars. In reducing teen smoking, there is a potential for multiple economic benefits in both direct and indirect savings. Direct savings come from the reduced need to provide healthcare to smokers, and indirect savings come from the greater productivity of non-smokers due to reduced number of sick days and longer working life. Various studies have found school-based teen smoking cessation programs to be cost-effective and cost-saving too. One study stated that a school-based smoking prevention program of modest success could produce an overall return of $15 for every dollar spent. Another study stated that the average expected lifetime medical care costs associated with being a smoker were nearly $9,400 more than those of non-smokers, and that with a yearly intervention cost of around $16,000, about $327,000 could be saved in medical costs. Knowing the potential savings from reducing smoking, and knowing that most adult smokers start as teens, the developers created and marketed this program to the demographic that would have the largest impact. As mentioned a few times before, not only was the program successful, but it was considered a model program by the ALA. It was successful due to the way the content was prepared and the way the program was delivered. The ALA recommended that schools offer the program as a voluntary, non-punitive measure to help students quit smoking. With this voluntary approach, schools were able to support students who wanted to stop smoking in a positive setting. By providing a supportive atmosphere, teens were more likely to feel comfortable sharing and opening up. When examining restorative versus punitive practices in schools, we see that providing teens with a safe and positive space allows them to create healthy and productive relationships with adults, which ultimately facilitates a positive school climate and learning environment. Using this type of mentality, the program was developed in a way that would help teens be successful in quitting. The program developers were also aware that the content of the program needed to be tailored to adolescent trends, issues, and learning needs. The program used teen-friendly language and focused on issues relevant to teens. In addition, it provided a wide range of ways to learn, from small group discussions and role plays to journals and hands-on activities. The program also encourages active participation by allowing participants to think about their experiences and behaviors, apply program concepts to their life, and practice new skills in areas such as communication and stress management. Teens also developed a sense of belonging through the program in that they were given opportunities to serve their schools and communities. So now that we know that the program was successful, what are the short and long-term effects? Preliminary analysis of data from the program found that 28% of participants quit smoking, and of those who didn't, most reduced the number of cigarettes they were smoking per day. Early on, the program results looked promising. Not only was the program helping teens quit smoking, but was also providing them with life skills to help improve their social and psychological health. These are some of the positive short-term effects of the program. Additionally, those who quit smoking will see their heart rates and blood pressures drop to almost completely normal levels within 2 hours, and risk of heart attack decreasing in 24 hours. People will also begin to notice the money they are saving that they would have otherwise spent on cigarettes. One of the negative short-term effects participants may experience is going through nicotine withdrawal, with symptoms including anxiety, increased appetite, irritability, sleeplessness, and cravings. Positive long-term effects might include continuing not to smoke, which in turn lowers one's risk for smoking-related diseases such as lung cancer and coronary heart disease. After 15 years of quitting smoking, nearly all of the body's restorative processes are complete, reducing one's risk of heart disease to that of someone who has never smoked. I had difficulty finding any negative long-term effects of participating in this program and quitting smoking, other than withdrawals can last for up to 6 months. So lastly, let's look at the scalability of KNOT. The program is easily scalable to other communities as well, and is continuously used in several different states throughout the U.S. However, there was an instance where the program was not as effective as it had been in the past. When the program was implemented in Alabama, researchers found that the program had little to no impact on teens quitting smoking. But when we look at how the study was conducted, we can see why it yielded such different results here than it had in the past. It turned out that the Alabama study simply failed to replicate the previous KNOT studies, as they changed a few of the methods. For example, in other KNOT studies, both the state and national ALA were involved in the implementation of the program, whereas in the Alabama study, only the state ALA was involved. In addition, the Alabama researchers failed to include some materials and procedures and other pieces of their methods that ultimately led to the skewed results of the study. So in order for this to be replicated, the program's methodologies need to be followed accordingly.